Imagine this. You're 73 years old. You feel completely fine. No pain, no symptoms, plenty of energy. You go in for a routine checkup, something you've done every year for decades. Your doctor suggests a few extra tests, just to be safe. 6 weeks later, you're sitting in a specialist's office. Not because you felt sick, not because something was wrong, but because those tests found something. And what happened after that discovery changed your life in ways nobody warned you about. This isn't a rare story. It happens every day across America, the United Kingdom, and Canada. And the research behind it is something every adult over 60 should understand before their next medical appointment. This channel exists for one reason: to give adults over 60 the honest health information that a 15-minute doctor's appointment rarely has time to explain. Today, you'll learn about 5 routine medical checkups that research suggests may cause more harm than good after the age of 70. Stay with me until the end, because number 3 could completely change the way you think about heart testing. And number 5 is something many people don't hear about until it's already too late. Before we get into the 5 checkups, there's one important idea you need to understand first. It's something I call the age risk shift. At age 50, routine screening can be incredibly valuable. You find a problem early, you treat it, and you may gain 20 or even 30 more years of healthy life. The benefits are often clear. But after age 70, the equation starts to change, and 3 things become very important. First, many conditions discovered through routine screening in older adults may never actually harm them. They grow slowly, they cause no symptoms, and in many cases, a person may outlive the condition entirely. But the moment it appears on a medical report, the treatment process often begins. Second, the body's ability to recover from medical procedures changes with age. A surgery that a 55-year-old recovers from in a few weeks may lead to months of complications for someone in their late 70s. Sometimes that means losing independence. Sometimes it means losing quality of life. And third, this is the one most people never hear about: the cascade effect. One routine test finds a small abnormality. That leads to another scan. The scan leads to a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, someone who felt perfectly healthy is dealing with a medical crisis that began with a test they may not have needed in the first place. Keep this framework in mind as we go through each checkup, because once you understand it, everything else starts to make sense. And before we continue, tell me in the comments, which country are you watching from today? Checkup number 1. Routine colonoscopy after age 75. Let me tell you about a woman I'll call Margaret. She was 76 years old, a retired school teacher, active, sharp, and completely healthy. During a routine visit, her doctor looked at her chart and said she was due for a colonoscopy. Margaret had no symptoms, no family history of colon cancer, and her previous 2 colonoscopies had been completely normal. Still, she agreed to the procedure. Not because she was worried, but because she trusted her doctor and didn't want to seem difficult. The night before the procedure, she drank the bowel cleansing solution. It hit her system hard. By morning, she was severely dehydrated, dizzy, weak, barely able to stand. Her daughter rushed her to the emergency room before she ever made it to the colonoscopy appointment. Margaret spent 4 days in the hospital, and in the end, she never even had the procedure. Here's the most important part. She probably didn't need it. For many older adults, the balance between benefit and risk changes after age 75. If you have no symptoms, no significant family history, and previous screening results have been normal, the potential benefits of routine colonoscopy may become much smaller. But the risks remain real. One of the most serious complications is a perforation, a tear in the wall of the colon. While uncommon, it can be a life-changing event for an older adult. What might be a manageable complication for a younger person can sometimes lead to emergency surgery, a long recovery, and a significant loss of quality of life in someone in their late 70s. So what are the alternatives? For some people, less invasive options may be worth discussing with their doctor. Tests such as stool-based screening can sometimes provide useful information without the risks that come with a procedure.
Checkup number 2. Aggressive PSA prostate testing and routine mammography for low-risk adults after age 75. Now, this is an important topic, and it deserves some nuance. I'm not saying cancer screening is bad. Far from it. Cancer screening has saved millions of lives. What I am saying is this. After age 75, aggressive cancer screening in people who have no symptoms and no major risk factors can sometimes create a different problem: overdiagnosis. And overdiagnosis often leads to overtreatment. So what does overdiagnosis actually mean? In simple terms, modern imaging technology has become incredibly sensitive. It can detect cancers that are growing so slowly they may never cause a symptom, never spread, and never affect a person's lifespan. In other words, you could live your entire life with that cancer and never know it was there. You would die with it, not because of it. But once a scan or test identifies a possible cancer, everything changes. More testing, biopsies, specialist appointments, treatment discussions. The process starts moving forward, even when the cancer itself may never have become a threat. Consider a man I'll call Robert. He was 78 years old, retired, still fishing on weekends, active, independent, and enjoying life. During a routine checkup, a PSA blood test came back slightly elevated. A biopsy followed. The results showed a slow-growing, low-grade prostate cancer. His specialist recommended treatment. Robert trusted the advice and moved forward. Within a year, he was dealing with chronic fatigue, persistent urinary problems, and a quality of life that had declined significantly. The cancer had been treated, but the treatment itself created challenges that affected his daily life. This is why doctors and researchers continue to debate the value of aggressive screening in older adults who have no symptoms and are considered low risk. Because finding a cancer is only part of the question. The bigger question is whether treating it will actually help a person live longer or live better. And that's the conversation many patients never have. So what should you do? Have an open discussion with your doctor. Ask a simple question. If we find something, what are the realistic treatment options at my age? And will treatment genuinely improve my quality of life or extend it in a meaningful way? That one question can completely change the direction of the conversation. And sometimes it leads to a much more thoughtful decision. Checkup number 3. Routine cardiac stress testing in people who have no symptoms. And this is the one that surprises most people. Imagine you're 73 years old. You go in for a routine checkup. Your doctor says, let's make sure your heart is doing well. So you're scheduled for a stress test. Maybe you walk on a treadmill. Maybe you're given medication that temporarily puts stress on the heart while doctors monitor the response. On the surface, it sounds completely reasonable. It sounds responsible. But here's where things get complicated. In people who have no symptoms, cardiac stress tests can sometimes produce false positives. In other words, the test suggests there's a problem when the heart is actually functioning normally. And once an abnormal result appears, it becomes very difficult to ignore. That finding often leads to additional testing. One common next step is cardiac catheterization, a procedure that involves threading a thin tube through the blood vessels and into the heart. While generally safe, it is still an invasive procedure. And like any invasive procedure, it comes with risks: bleeding, blood vessel injury, heart rhythm problems, and in rare cases, serious complications. But the story doesn't always end there. If the procedure finds a partial blockage, and that's extremely common in older adults, even those who feel perfectly fine, you may be advised to consider a stent. Many people assume that finding and opening a blockage automatically prevents future heart attacks. But for people with stable heart disease who have no significant symptoms, the evidence is more complicated than that. Large clinical studies have shown that medication, risk factor management, and lifestyle improvements can often provide outcomes similar to invasive procedures for many stable patients. Which means the path can sometimes look like this. You feel fine.
A routine test finds something suspicious. More procedures follow.
Checkup number 4. Routine bone density screening followed by automatic medication. Now, let's be clear. Bone loss is real. Osteoporosis is real. And falls in older adults can have life-changing consequences. So this isn't about ignoring bone health. It's about questioning the automatic treatment pathway that often follows a bone density scan in adults over 75. Here's how it usually happens. A DEXA scan shows low bone density. The result comes back, and almost immediately, the conversation turns to medication. Drugs designed to strengthen bones and reduce fracture risk. Many people start taking them, believing they're fully protected. But there's another side to the discussion that isn't always emphasized. Some osteoporosis medications, when used for many years, have been linked to rare but serious complications, including unusual fractures that can occur with little or no trauma. These events are uncommon, but they are important enough to be part of the conversation. Now, here's the part many people find surprising. The most powerful strategy for preventing fractures often isn't medication at all. It's preventing the fall from happening in the first place. Because most fractures begin with a fall, not with weak bones alone. That's why experts place so much importance on balance, mobility, and home safety. Simple changes can make a remarkable difference. Improving balance and strength, removing loose rugs and tripping hazards, installing grab bars where needed, reviewing medications that may cause dizziness, getting enough protein, maintaining healthy vitamin D levels, and staying physically active. These steps can dramatically reduce the risk of falling. And unlike medication, they come with virtually no treatment-related side effects. So before automatically moving to long-term medication, consider asking your doctor one important question. Can we first review all of my fall risk factors together? That single question often leads to a much broader conversation, and sometimes a very different treatment plan. Checkup number 5. Routine carotid artery ultrasound screening in people with no symptoms. And this may be the most important conversation in this entire video, because it's a test many people have never even heard of, yet it can lead to major medical decisions. A carotid artery ultrasound looks at the large blood vessels in your neck, the arteries that carry blood to your brain. The logic seems straightforward. Find a blockage early, treat it, reduce the risk of stroke. On the surface, that sounds like common sense, but the reality is far more complicated, especially for people who have no symptoms. Here's why. Many adults over 70 have some degree of narrowing in these arteries. In many cases, it's been there for years, stable, silent, and causing no problems at all. The issue begins when routine screening discovers that narrowing, because once it's found, the pressure to do something about it often follows. More appointments, more testing, and sometimes a recommendation for surgery or another procedure. The problem is that every procedure carries risk, and when a blockage isn't causing symptoms, the potential benefits may be much smaller than people assume. In some cases, the procedure itself can create complications, including the very outcome everyone was trying to avoid, a stroke. That's why many experts focus on a critical question. Will treating this finding actually improve the patient's future health? Or are we treating a problem that may never have caused harm in the first place? This is where the concept of the age-risk shift becomes important again. Finding something isn't always the same as helping someone, and in older adults, that distinction matters a lot. So what should you focus on instead? The risk factors that have the I
strongest
promised you
connection
something
to stroke
practical.
prevention.
Here
Blood
it is.
pressure control,
5
blood sugar
questions to
management,
bring to every
avoiding
medical
tobacco,
appointment from now
managing
on.
heart rhythm conditions,
These
such as
questions
atrial
can
fibrillation,
completely
staying
change the
physically
quality of the
active,
conversation,
and maintaining
and
overall
they may
cardiovascular.
help you make better decisions about your health. Question number 1. What is the false positive rate of this test for someone my age? In other words, how often does this test suggest there's a problem when there really isn't? This question helps you understand the likelihood of unnecessary follow-up testing and procedures. Question number 2. If this test finds something, what are the realistic treatment options for someone my age and overall health? This shifts the discussion away from simply finding abnormalities and toward what can actually be done about them. Because a finding only matters if it leads to a meaningful benefit. Question number 3. What are the risks of the treatments or procedures that would likely follow? Every procedure carries some level of risk, no matter how routine it may seem. You deserve to understand those risks before making a decision. Question number 4. What happens if we monitor this instead of treating it right away? For many conditions in older adults, immediate treatment is not the only option. Sometimes careful monitoring is a reasonable approach, and in certain situations, it may even be the better one. Question number 5. What is the most effective non-invasive option available? Because in many cases, the biggest improvements come from changes that don't involve procedures at all. Lifestyle, physical activity, nutrition, sleep, fall prevention, managing blood pressure, managing blood sugar. Simple interventions often produce powerful results, and they usually carry far less risk. The most important thing to remember is this: a good doctor will welcome these questions.